Welcome to this session on treatment mapping, a review of ovarian cancer treatments around the world. I'm Reid and I'm Programme Director for the World Ovarian Cancer Coalition. For decades, the standard of care for ovarian cancer has involved surgery to remove as much of the tumour as possible, and for those with disease that has spread, chemotherapy involving usually a taxane and a platinum-based agent, for example, paclitaxel and carboplatin. That is for the most common forms, the epithelial ovarian cancers. For non-epithelial types, combinations of treatments such as bleomycin, etoposide, and cisplatin have been used. But as you'll hear over the course of our two-day meeting, the landscape for ovarian cancer treatments is expanding. We've had VEGF-A and PARP inhibitors, and in some places now, the standard of care is changing. So at this potentially game-changing point in the management of ovarian cancer, and in the light of our Global Ovarian Cancer Charter goal on improving access to treatment and best possible treatments, the Coalition decided to explore in more detail how access to vital ovarian cancer drug treatments, both old and new, vary around the world. And if you're affected by a lack of access, either as a clinician, as a patient, or a patient organisation, please do share your experiences in the chat box at any time. And we'll be discussing the findings shortly with our expert panel for today. I'll introduce them in a little while. But first, I'd like you to be introduced to Mikis Euripides, who has undertaken this work on our behalf, and he will take you through the results.
Hello, my name is Mikis Euripides, and I'm the project lead on this ovarian cancer treatment mapping project. So from the beginning, the reason that we put this project together was to raise the profile of ovarian cancer treatment and make a contribution to this global conversation about access. There have been a number of reports recently, which I'm sure you know about, in particular the WHO report on pricing and cancer medicines and the UICC report on access to cancer treatment. So we hope that this makes a contribution to that debate. The first thing that we did was to create a comprehensive list of ovarian cancer treatments available globally. We used a number of sources, including the NCCN and other sources, NICE, NCN, and others, to create 5 categories of ovarian cancer treatments and to have at least one drug available within each of these different categories. I've listed the categories there. Chemotherapies for epithelial ovarian cancer, chemotherapies for non-epithelial ovarian cancer, VEGF, PARP inhibitors, and hormone treatments. So we created this list and we used this to approach clinicians in 13 countries. The countries that we selected were a broad range of countries that were covered, that would cover the income brackets that are under the classification of the World Bank. You can see the countries there: Australia, Canada, Italy, UK, USA, and Uruguay are high-income countries. Mexico, South Africa, upper middle-income countries, Bangladesh, India, Nigeria, and Zambia, low middle-income countries, and our sole low-income country is Sudan. We also sought input from colleagues in the pharmaceutical industry, directly to them, asking them about their products only, and specifically about licensing and reimbursement status of their products in those 13 different countries. By way of context, you can see here a timeline of when each agent was first approved. So you can see as far back as the 1970s, when some of these treatments were first approved by the FDA in the US, right up until the last decade or so, where the newer treatments, the PARP inhibitors, see the here represented by the blue colors, were approved by the FDA. So these are all the 15 treatments that we noted in our comprehensive list of ovarian cancer treatments. What's interesting is that all of these treatments, except the PARP inhibitors, are also on the WHO essential medicines list. So starting with our clinicians. So the question here that we're looking at is, which of the 15 drugs are routinely available in each of the 13 countries that we have listed here? And this graph essentially shows from left to right the higher income countries on the left, right down towards the sole low income country Sudan. What you can see is here, looking at the different colors, you can see For example, the PARP inhibitors represented by the blue colors here is as you move down towards the lower income countries, there is no routine availability of PARP inhibitors, and there is also minimal routine availability, or few countries that have routine availability of the VEGFR treatment here, bevacizumab. So the high income countries tend to have more drug classes available to clinicians. Upper middle income, low middle income countries, and Sudan, the so low income country, tend to have fewer drug classes routinely available, and within the classes, fewer agents routinely available. And Zambia is an extreme example of this, as you can see. So Zambia has none of the 15 treatments that we have listed as routinely available. And the countries that do not have PARP inhibitors routinely available are all non-high income countries. So Mexico, Nigeria, South Africa, Zambia, India, and Sudan. So none of these countries are high income countries. So what we have here is routine and occasional availability of ovarian cancer treatment. So we're capturing both occasional and routine when we're asking our clinicians in those 13 different countries. And what you can see here is that Zambia has occasional access to the older chemotherapy and hormone treatments, but essentially the targeted agents remain unavailable. Interestingly, Uruguay, as a high-income country, has access to agents from each of the treatment groups. Fewer agents in each group are available in comparison to other high-income countries. And also interestingly, Nigeria has access to all of the 15 treatments that we have in our list, which is unusual outside of our 6 high-income countries. So while there are a few outliers, there is a tendency for high-income countries to have access to more of the treatments compared with the upper middle income, low middle income, and the sole low-income country. So what we have here is looking at the different classes of drugs. Remember the 5 different classes that we noted at the beginning, and which of these are unavailable. The key points to note here is, again, as you move from the older treatments on the left right up towards the right where there are the newer treatments, you can see that there are more countries where it's unavailable. In summary, the PARP inhibitors are the most frequently unavailable of the class of agents out of this group. And even within the PARP inhibitor class, there is variability. And chemotherapy agents for non-epithelial ovarian cancer are available in all countries. However, topotecan and pegylated liposomal doxorubicin are unavailable in 1 high-income country and 1 low-middle-income country, and 1 respectively. Letrozole is also unavailable in South Africa. We also asked our clinicians about what they understood to be the payment arrangements, or who was paying for the different treatments that are available in their country. And interestingly, the higher income countries, the state pays for approximately or nearly 75% of the drugs on our list. And as you move towards the lower income countries, lower middle income country and low income country in particular, you've got over 50% of those treatments are paid for out of pocket by the patients. Also, what's interesting from this is that, according to our clinicians, the pharmaceutical companies are not involved in paying for ovarian cancer medicines in the low middle income countries and the sole low income country surveyed. What we also did is we looked at sources of health expenditure. And what we did is we just made a brief comparison of some WHO data. And this is from the WHO Global Health Expenditure database from 2018. And what you can see is some interesting or similar trends that emerge when we put our results from our clinicians next to what the WHO Global Health Expenditure database is telling us. So, for example, Australia, the United Kingdom, Italy, and Canada, the government is the largest source of funding for ovarian cancer medicines, according to our clinicians, but it's also the largest source of funding for more broadly in health expenditure, according to the WHO database. For Mexico and South Africa, there's more of an even split between the different payment groups. I should also note here that the WHO database has 6 different categories, whereas we have only 4 in our surveys. So the WHO included a subsplit of insurance and also includes external aid and an other category. But nevertheless, you can see that there are some similar trends when we look at the WHO database and our results from our clinicians. And the final point there is that in Bangladesh, India, and Nigeria, out-of-pocket or patient expenditure is the main payer class in our research, which agrees with the data from the WHO broadly. As I mentioned at the beginning, we did also reach out to the pharmaceutical industry, specifically the manufacturers of the VEGFA and the PARP inhibitors. And we asked them a different survey, but essentially we did ask them about the licensing and the reimbursement arrangements. We also asked them about if there were any broader access challenges that they had when it comes to their treatments in the countries that we discussed. But we haven't covered that here. What we do have is essentially those 2 questions around licensing and reimbursement. And again, this seems to back up what our clinicians are saying. And what we can see is one of the PARPs, we call it PARP A, licensing and reimbursement occurs in high-income countries and upper middle-income countries, but that's just one PARP. For the VEGFA, there are also low middle-income countries in which the agent is licensed, but the drug is only reimbursed in high-income and upper middle-income countries. So the project parameters, this is very much a snapshot. The work was carried out between March and August of this year. The information was provided to us by clinicians and their own experiences in their own settings. And also the information from industry is accurate up to the date it was provided. The other point to note is we do know that some countries they have a federal structure and decisions are made at both national and also sub-national levels. So for example, in the United Kingdom, the devolved administrations make decisions when it comes to access and reimbursements. There are some similarities with Italy as well in terms of the countries that we surveyed, but we asked the questions very much at a UK level, so please note that as well. The other point there at the end is that obviously this is a highly complex area. We are making a contribution to the debate, but there are many, many other factors influencing availability and access to treatments. For example, the structure of healthcare systems, regulatory challenges, policy, priorities. We haven't really delved into that when it comes to this work that we've carried out, but they are covered in those 2 reports I mentioned right at the beginning to a lesser extent in the WHO report, but particularly in the UICC report of 2019. So just in summary then, essentially this is a worrying picture that is portrayed here. There is a wide variation in the treatments that are approved at country level, as well as in the access to approved treatments between and within countries. Clinicians are telling us that in the high-income countries, more of the 5 classes of drugs are routinely available to them, whereas in the upper middle income and low middle income countries, they have fewer drug classes routinely available. Zambia stood out as the only country where none of the 15 treatments are routinely available. And where treatments are routinely available to women in those low, middle, and low income countries, they are largely restricted to the chemotherapies and hormone treatments, some of which were approved over 40 years ago, such as cisplatin and tamoxifen. The PARP inhibitors are the least routinely available, with almost half of the countries not having any PARP inhibitors routinely available, and only 3 of the countries, all of which are high-income countries, having all 3 of the PARPs routinely available. And most disturbingly, women in low and middle-income countries appear to pay out of pocket for more than half of the drugs on our list, whereas in the high-income countries, the state pays for 3/4 of those drugs on our list. And given that 29.6% of women with ovarian cancer live in high-income countries, this shows the devastating impact that access to medicines can have on families' finances. You can see there that in upper middle income countries, there's nearly 40% of women with ovarian cancer, and in low middle income countries, 27%, and low income countries, 3%. Finally, the World Ovarian Cancer Coalition would like to thank clinicians and industry for supplying us with this information.
Thank you, Mikis, for that. It's been a highly complex piece of work to undertake, but some really important key points. New developments not widely available, especially in low and middle income countries, and even access to older treatments is an issue, either because they're not available or because they are unaffordable. Patients in low and middle income countries facing the risk of financial catastrophe. And if you were in our earlier session on the Every Woman study, you will have seen that 70% of women with ovarian cancer in the world live in lower and middle income countries. Globocan, who are the source of cancer statistics and predictions, say ovarian cancer incidence will increase by 40% by 2040, and the greatest burden of that increase will actually be felt in lower and middle income countries. So it's a growing problem for us in the ovarian cancer world. PARP inhibitors, been described and will be described tomorrow in one of our sessions as having a profound impact on the treatment of women with ovarian cancer, and have efficacy in up to half of the women who have ovarian cancer. One of the studies, the solo one, for women with a BRCA mutation, you saw a difference in median progression-free survival from 56 months with the PARP inhibitor versus 13.8. I mean, quite transformational, really. And up to 23% of women with ovarian cancer have a BRCA mutation, but the PARPs can benefit up to 50% of women. And we did back of an envelope calculation, and the costs that we could get hold of for one of the PARPs was $3,000. For one PARP was $3,000. Monthly cost was $3,000, and it would take an unskilled worker over a year's salary to be able to afford 1 month of PARP in India. And for those on the maximum unskilled worker salary, it would take 4 months to earn enough just for 1 month of treatment, and the standard of care is 2 years. So some sobering thoughts, really, and time to introduce my panel, because they hopefully will help us unpack some of this and see how this compares to other conditions as well. And we want to hear again from you if you have experiences and what you think we as the coalition should be doing with our collective voice to help this move forward. So I'm delighted to introduce you to our panel, and they have considerable expertise in this area. So Runcie CW Chidebe is our board member and a powerful advocate for people with ovarian cancer in his native Nigeria, working through his organisation Project Pink Blue. Julie Torode is Director of Strategic Partnerships at King's College London and is former Director of Special Projects for the Union for International Cancer Control. And Professor Christopher Booth, I should say Dr. Julie Torode, I should have said, and Professor Christopher Booth is Professor of Oncology and Public Health Sciences and the Canada Research Chair in Population Cancer Care, based in Kingston, Ontario in Canada. And he's just published a paper last week in Lancet Oncology on this subject. And both he and Julie have worked together on the essential medicines list for the World Health Organization. I'm going to come to each of you in turn for some very top-line thoughts, 30 seconds to a minute each, starting with Runcie on what you've heard already.
Okay, thank you very much. For me, this is really exciting, but at the same time as well, it's really sort of scary. And exciting in the sense that, for instance, Nigeria has all the 15 medicines, but having our access to this medicine, it's really a serious issue because not most of the women can really afford it. So that these medicines are available, affordability is an issue, considering the economic capacity of most of these women and where they live. Nigeria, for a country of over 200 million people, we have just randomly about less than 20 cancer centers across the entire country. Yeah, so it's really exciting to be here to contribute and reflect on this and see what we can do globally and nationally and locally to really change this narrative. And thanks to the coalition for inviting me to be part of this.
Thank you, Runcie. Julie, your initial thoughts?
Thanks, Francis. My immediate reaction was, wow, what a great advertisement for universal health coverage. Those countries that are providing medicines free for patients are having great impact as far as equitable access to those medicines. And what those countries that aren't able to even address universal health coverage at all, we're having struggles. It's not an unusual picture. Yeah, we see this in all cancers, and it's great to welcome the coalition to this discussion. We really need to step up and push hard, particularly reacting as we come out of the COVID pandemic. We must build back cancer services as quickly as possible. So great advertisement for really looking at universal health coverage.
Thank you, Julie. Chris, your initial thoughts, and then if you can take us into the paper that you published just last week and what it showed.
Great, thanks, Francis. It's a privilege to be part of this discussion. I just applaud the coalition for actually having a session like this, because I think that I'm sure together with Runcie and Julie will outline some challenges on the ground and from a policy level, but the solutions to this are actually going to come from the patients and advocates. And so we need to kind of speak as a united voice, I think. So it's really powerful that your coalition is leading this work. I think just my initial thoughts about the data would be that, it's sobering. There's obviously exciting new treatments coming down the pipeline for ovarian cancer and many forms of cancer, but the data we saw is sobering. And I'm going to make a provocative statement, and perhaps we can open it for discussion later, but I would argue that if we are serious about reducing suffering from ovarian cancer worldwide, then we need to act on the information we already have and ensure that women worldwide have access to the treatments we already know work, and not necessarily focus on a new technology, new antibody, new robot, new scanner that we might have in 3 months, 6 months, a year, or 5 years that might help a handful of patients in very rich countries. But if we want to really make a dent in the burden of this disease, we need to ensure that the treatments that we already know work right now are widely available and in an affordable context. So I would just maybe start with that. So I'm happy, I'm going to walk the group through a little bit of the project that we've just finished. And so this was, we called this the Desert Island Project, and I'll explain the background to the name in a moment. And so as Francis mentioned, I'm a chemotherapy doctor, a medical oncologist in Canada, and I do work with Julie and others on global health policy. And a number of us have worked with the World Health Organization Essential Medicine List Cancer Working Group for many years. And the Essential Medicine List is a process whereby it's updated every 2 years, and a number of experts from all over the world come together to identify which medicines across all diseases are truly essential. And they consider the benefits, side effects, costs, the feasibility, and other treatment options. And this list is updated every 2 years. While the list is meant to serve all countries worldwide, the reality is that many high-income countries and high-resource health systems already have a process for health technology assessment to understand which medicines will be available and will be paid for. So the Essential Medicine List really is most useful in lower and middle-income countries that perhaps do not yet have those systems and processes in place. And so the hope is that by listing a medicine on the EML, it allows ministries of health and policymakers at countries worldwide to prioritize procurement and making that medicine widely available for patients, ideally in the context of a universal health system. So that's the background about what the EML is and why it exists. And so Julie and I and others have been on a cancer medicine working group that has provided advice to the EML Central Committee. And every 2 years, the list is updated. And so over the last few years, a few of us have pushed back gently and said, we need to go beyond a bunch of experts in a boardroom in Geneva that come up with a list. We need to actually understand on the front lines, in the real world, are these medicines actually available? And are these the medicines that doctors and nurses on the front line of care really want? And so together with teams, with our team at the WHO and investigators from really all over the world, we launched this project we called the Desert Island Project. And the goal of the project was we surveyed 1,000 oncologists in 82 countries, and we wanted to learn from them which medicines they felt were the most important for cancer and whether those medicines were available in routine practice. And the way that we asked them this question through the survey was using this hypothetical, what we call the desert island thought experiment. Many of us have done this before at dinner parties, where in conversation, a friend might ask you, if you were moving to a desert island and could only bring 3 books, what would it be? If you could have dinner with one famous person in history, who would that be? So the thought experiment here was, in the survey, we said something like, imagine your government has put you in charge of cancer care. And the prime minister or president has told you that you can choose any cancer medicines for the people of your country. Cost is not an issue. They will be free of charge, but you can only choose 10. Which 10 medicines would you choose for your country to provide the greatest public health benefit? And so it was, in some ways, an artificial construct. We forced people to choose 10 medicines. And then the second part of the survey was, we said, okay, thank you. You've told us your 10 medicines now that you'd like to have. Let's go to real life. How available are these medicines for you and your patients in the real world? And so the answer to the first question, we found that when we looked at the most highly ranked drugs, the 20 drugs that were ranked over and over again, first of all, the vast majority of them are old, generic, inexpensive chemotherapy drugs and hormone medicines. Okay, so the drugs that doctors want the most are the ones with the biggest benefit that tend to be older and should be cheap and should be affordable. There were some newer, more expensive targeted drugs on the list, but they were the ones that you would expect based on the fact that they have large benefits for patients. So the list actually made sense, but it was a bit probably eye-opening that it wasn't dominated by all these new expensive fancy medicines. It was really dominated by stuff we've been using for 20, 30 years that we know makes a big difference for the lives of our patients. We also found that there was a lot of agreement across different systems. So when we looked at oncologists from high-income countries, upper middle-income countries, and lower middle-income countries, we found that across the top 20 drugs, 15 of them were identical. So there was a lot of convergence across oncologists worldwide, and these medicines, with almost, with very few exceptions, were already on the essential medicine list. So in some ways, this was maybe the good news part of the story. Now I'm going to get to the challenging part, and this was when we asked doctors, are these medicines available? Recognizing that most of these are old, generic, inexpensive drugs, the results were shocking. And I think this should be a call to action for our community. So we found that even for these very old, cheap drugs in lower middle, and to some extent upper middle income countries, these medicines are still not affordable, and they are still out of reach for the vast majority of patients. So I have data here. So I can tell you actually within, very highly ranked within the most important medicines worldwide were drugs that matter to women with ovarian cancer. So carboplatin and paclitaxel were highly ranked over and over again on this top 10 desert island list. So obviously these medicines have a big impact for our patients, not just in ovarian cancer, but across other diseases, and they really matter. They've also been around for quite a long time. So here's the sobering part, and I'm just looking at the manuscript here. Which is actually, I should mention, and perhaps Francis and the organizing committee, the paper, it was published open access in Lancet Oncology, so perhaps the organizers can distribute a link for members of the coalition who would like to see this themselves.
It should be, we'll put it on the portal. Yeah. That's
great. So carboplatin, old drug, should be widely available. When we looked at low income and lower middle income countries, only 1/3 of oncologists said they could get this medicine for all patients for free of charge, only 1/3. Another third said they could get it for patients, but with risk of serious financial out-of-pocket expenditure, and 1/3 said that it would only be available for patients in their clinic with catastrophic financial toxicity, meaning that patients would have to spend 40% of their household dollars to get access to that medicine. So really we found, and the same results for paclitaxel, again, about 1/3 of patients could only get this if they spend basically half of all of their household money on this medicine. And so this is a real tragedy. When we move to upper middle income countries, we see what I call almost a dose effect. So each step through economic systems, you see that affordability and drug access improves. But we still see that, you know, between 10 and 15% of patients in upper middle income countries would have significant financial toxicity to access these old medicines. And by the time we got to high income countries, again, about 90% of women can access this in the context of a universal healthcare system, but 10% of women will still have some significant out-of-pocket expenditures. So I think, you know, the summary from this piece of work was that the drugs which really matter, that have a big benefit for patients, tend to be older drugs, which should be available because they're inexpensive. But we found that there are still striking barriers to access, largely in low resource health systems where we know that the cancer rates are rising most rapidly. So I think as a community, we need to, need to take action. And there's solutions here, which I'm sure we'll talk about over the next few minutes. And I think it behooves our community to consider these carefully. Thanks,
Thank you, Chris. Julie, universal health coverage. Is that the answer? Julie, you may be on mute, Julie.
Sorry about that. It's part of the answer, but I think the real question, first of all, is who's in charge of these processes? You know, we know that many countries, you know, WHO creates a model list. Countries then need to work out their own list. Who's in charge of the national essential medicines list? And at the time of the big update of the WHO cancer list, we did a check of the national lists that are registered with WHO, and in fact the model list was catching up with the national list, so they're good lists. But I don't think much of the oncology community engages with these lists. Who procures? What type of forecasting expertise they have? And what we find with the routine availability is that very short-term buying of medicines, no planning ahead. And we've seen a big problem with COVID as well, where those clinics that don't plan ahead, don't have a long-term forecasting, have really struggled. So there's some skill sets, but I think the clear story is we as an oncology community have to get much more involved in this procurement process and prioritization. And it's quite shocking that those top 20 medicines that almost every oncologist agrees are the top 20 that everyone should have in their kit, and we don't get them routinely, except for Nigeria. It's great to see that Nigeria has made progress there. Yeah. And the question is, you know, what has happened and how can we share those learnings in other settings?
Very, very good question to Runcie. What has happened in Nigeria, and actually what is it really like though on the ground? As you say, you mentioned a lot of financial outlay.
Yeah, I think, looking at this data, as I said, I had just mixed feeling. A lot has really happened over the past few years. We've seen a remarkable difference in terms of, advocacy over awareness. We've seen really massive advocacy targeting at government at different levels. Surprisingly, Nigeria just a few weeks ago just launched a new program known as CHF, that's catastrophic health financing for cancer. So what that means is that the federal government is able to support indigent cancer patients with funding to help them with their cancer needs. As you may be aware, about approximately 60% of healthcare services are provided by private sectors and 40% by the government in Nigeria. So this is also replicated in most African countries and most low and middle income countries. So there is no universal health care, in many low and middle income countries like Nigeria. Yeah, so the country's national health insurance scheme For instance, in Nigeria, covers less than 5% of the entire country, and cancer is not included. So what it means is that if you have any form of cancer, even if these drugs are available, you really may not be able to afford these drugs. So a lot is changing, and I think this is really a wake-up call or call to action to other low and medium income countries to understand the benefits of advocacy over awareness. What we see in many African countries, which I have been a frontline advocate for that, is we need to step up our game in advocacy. And you can't really blame many of the cancer or patient organizations that invest more in awareness than investing in advocacy, because advocacy is so difficult, is so expensive, there is threat to it. Sometimes your life is also being threatened, sometimes you get arrested. A lot of things. Like today, I was making a presentation and I said that the ban of Twitter in a country like Nigeria should not be seen as just a human rights issue. It should be seen as a global health issue and a cancer control health issue. Because me as a person who runs Project Pink Blue like an organization in Nigeria, we raise thousands of dollars on Twitter. During my birthday, I raised $2,000 in less than 48 hours on my birthday for cancer patients for radiotherapy. So banning that tool for the past 6 months now is a cancer control issue. But a lot of scientists, a lot of advocates all over the world are not seeing it that way. They're seeing it from just the shrinking of civic space, is the shrinking of global health as well. So a lot is changing, but I think the progress is really not matching where we want to be. But thanks to this data, because this data is clearly showing the need for meaningful collaboration between all stakeholders to see how we can make progress, see what we have and what we need to change, to bring progress to our community and to truly have global partnership.
Yeah, I come to Chris now. Thank you, Runcie, because I want to pick up on a couple of points about that and about the communities coming together and planning going forward. How do people assess these drugs? Now, you've said that they vary from time to time, and your list was drawn up by it will help the most people, but that's not the only thing that comes to play, is it? Finance often comes into it, the cost of the individual drugs.
Yeah, it's a great point. So, a few thoughts just to build on Runcie's very insightful comments. The first is that I think we do need advocacy and activism, and I think that the oncology community could probably learn from our colleagues in the HIV world who decades ago had highly effective medicines, which for a number of reasons were not widely available because of lack of affordability, and they mobilized and they were very successful in allowing policies to change such that these medicines became more widely available. So I think we can learn from other members of our community. The second point, I guess, just to mention is that to recognize that cancer medicines are just one part of a high-functioning cancer care system, and we need to strengthen primary care. We need to have health promotion literacy to ensure that women with ovarian cancer are diagnosed in a timely fashion. And we need to ensure that the other parts of cancer care are given equal attention. So sometimes, these expensive cancer medicines get all the attention, but if someone can't have access to safe, high quality surgery, then getting all the fancy antibodies in the world is not going to make a difference. So we need to have access to the platform services. We need to invest in pathology and imaging, and of course support our partners in primary care and palliative care to ensure that symptoms and comfort is managed. I'm going to make maybe a provocative statement about the magnitude of benefit of treatments. So the cost is certainly an issue. But I think that as a community, we can do a better job of identifying those treatments that actually make a big difference from those that do not. And I would argue, I don't treat ovarian cancer. I'm a medical oncologist that treats mostly GI cancer, colon and pancreas and gastric. But from what I know of the medicines that we talk about in ovarian cancer, some of them have huge benefits, major benefits. And those are the ones that came out near the top of our list when we surveyed doctors. But I'm going to suggest that some of the medicines that are standard practice do not. Yeah. I'll be provocative and say bevacizumab has a very small benefit in this disease. and that if we want to make a big difference for women with ovarian cancer, we should focus on other elements of cancer care rather than one of these newer medicines that has, I would argue, a marginal benefit, not just in ovarian cancer, but across other cancers. So I think we need to be willing to recognize that not all these medicines have the same benefits for patients.
I agree with that, but to show, I put the point about the impact of PARP inhibitors and how that may change in the future. We also have the question in ovarian cancer where the standard of care for example, low-grade serous is the same as it is for high-grade serous, but in actual fact, the efficacy is really not there. And we will certainly come to the point when there are new developments where that old standard of care will get blown out of the water because, 15% respondents, 20% responding to a treatment, you're putting women through a lot of treatment for very little gain sometimes. And that's one of the important issues to discuss. I totally agree with your point about strengthening access to surgery and strengthening diagnosis. They're both big issues that we at the coalition do really care about. But question to you both, for us at the coalition and for individual partner members, how do we really maximize our voice and contribute to the discussions, because it is such a complex area? Should people be advocating in their countries for universal health coverage? Should the patients who are having to be paying out of pocket be standing up and saying, is this right? Why can't we have access to some of the fundamental medicines of cancer care? Where should we be focusing our effort? Julie, would you like to have a go first?
Sure, Francis. And I think we should use these global commitments as a good framing. All of our governments have signed up to achieving, or at least trying to achieve, universal health coverage by 2030. So that gives us a 10-year or 9-year now time frame to really have a look at this. All of our governments have also signed up to 80% availability of essential medicines for non-communicable diseases. So again, another lever where commitments are already there. But I think the real plea is to work together. I don't think it's a good idea to focus on any one drug group and sort of shout about that. What we need to show is, we're investing in these patients, we're diagnosing them, we're giving them good surgery, and then we're not quite finishing the job because we're not giving them the optimal treatment. So showing that by providing these medicines, you're actually getting the outcomes you want, rather than a half-finished job, and therefore not a good outcome, is I think the way to go. But also showing where that's cost saving. And I think that you can do a back of the postcard calculation, but maybe we should be thinking about what some good economic analyses to show the investment that we're making, not the cost, but the investment we're making in cancer health systems from the perspective of ovarian cancer.
That's really interesting. Chris, do you have any thoughts?
No, I would agree, just that I don't think we should be siloed in either drugs or diseases. I think that accessing, the drugs we're talking about for ovarian cancer are often used in other types of cancer too. And so I think having coalitions from different disease groups come together in a united voice to say that, and the advocates don't necessarily need to have all the solutions. These are really complicated, but I think just by speaking out and saying, this isn't right, we care about this. I think this voice needs to come from all countries, not just low resource settings. I think that it's more powerful if it comes from patient advocates all over the world, rich countries, poor countries, and in the middle. And so I think it's a united voice that will stimulate our global leaders and policymakers to come up with, there are solutions to this. They're complicated, but there are a number of solutions that can be implemented. And I think the activists and the advocates and the coalitions just need to demand a more equitable system where affordability is not a barrier to high quality care.
So within a particular country, you'd certainly recommend groups getting together with other cancer advocacy groups for different disease areas to talk about this, share their experiences and see what they can do.
Yes, I would think a unified voice will be much more effective than fragmented voices. I think I would agree with that.
Runcie, in Nigeria, the cancer voices that come together, is that a common thing yet, or is this a new area of activity?
Yeah, I think that Nigeria has really been so lucky to have a huge number of advocate organizations that are, coming together every single time. And really thanks to the UICC for always using its different global platforms to bring people together. I think it's such a wonderful thing. And also the UICC Young Leaders Program, which helps to look at the new generation, because when you think about advocacy, especially in Africa, in Nigeria, it's gradually changing from the dimension of people just talking and organizing locally, but now moving to where people are not just organizing locally, but people are writing articles, people are going on Twitter, hosting tweet chats, and tagging the policymakers, making all the noise and all the rest. So it's changing, having, looking at the new generation with programs and interventions that target younger folks, younger advocates, will really help us to make progress more. And I also think localizing this information is so important. In the previous section, we were talking about translating some of the World Ovarian Cancer information into local languages. That is really phenomenal, because that's the way advocacy can really get very closer to the people, and people can own these issues and see that if we drive the process, it will definitely be for our own good and not for the good of maybe someone in Europe or someone in America and all the rest.
Yeah, so strengthening voices, and it's thanks to people like you and the work of people like the UICC. We just have a few minutes left. Julie, I was going to come to you first on this next question, and that is, can we learn anything from COVID? Which, in terms of global health equity, isn't necessarily a positive thing at the moment in terms of vaccine, but are there some lessons that we can learn from the COVID outbreak in all of this?
As far as access is concerned, I think what we really need to do is make sure we bundle the costing exercises. So if we're looking at the PARP inhibitors, for example, we do need to look at the BRCA testing. We know that those are immediately beneficial groups. So how do we factor that in? So it's not just the medicine, it's also the test. Obviously, we've seen a shift to oral medicines during the COVID pandemic. But, I think we do need to look at whether patients feel comfortable with that. Is it safe for patients, maybe with less oversight, especially with newer medicines? So maybe that's also an area for the coalition to look at, to really try and bring that patient preference data to the fore, so that when we're also looking at making decisions around drug use, then we can also bring those patient preferences in.
Yeah. It's interesting, we don't have them as part of the discussion today, but a group, one of our charter champions in Calcutta, are incredibly involved with the clinical community, investigating the affordability of PARP and low doses, and in having discussions about what would they actually be prepared to pay, what could they pay, as a sort of way forward in trying to find a sort of route through. So the patient voices can be incredibly powerful, and I know it's shaping their thinking very strongly indeed. Runcie, do you have any thoughts on lessons to learn from COVID?
Yeah, I think a lot of things to learn. COVID has truly shown that we have the capacity to provide care to everyone, no matter where they live. But it's just that we are not really ready to really do that. For COVID to just come out in 2019, and right now we have a vaccine and stuff like that, it shows that we have the capacity, but just that we really don't have the will. So I think same is applicable to, Chris was just talking about the treatment that we have today. Does it work? That's a very, very serious question, because if you think about it, some of the essential medicines are really not field tested in many low and medium income countries as of today. Today in Africa has about 109 open oncology clinical trials, and that is mostly located in Algeria, Egypt, Kenya, and South Africa. Nigeria as a country has only 6 oncology clinical trials, even though the country has mortality, of cancer rate like the highest in the whole of Africa. So based on this information and many other data you can see, and also looking at COVID, and right now there are vaccines in Nigeria, so it means that we have the capacity. What we need globally is to come together to see what this disease have taught us, that no matter where we are, if everyone is not protected, no one is protected. So I think we have a lot to learn, but I don't know if the will is still going to be strengthened after COVID, or are we going to go back to business as usual?
Chris, business as usual? You hope not, I guess, but...
No, I hope not. I must admit, I don't have much to add after that very eloquent answer from Runcie. I mean, I think that we've learned that global health matters, that it's not going to be in anyone's interest to just focus on diseases and cancers in our own backyard. We really are a global community, and that we should remember that. I think it speaks to the concepts of, as Julie raised earlier about universal health coverage and health system strengthening. I think there's going to be, hopefully renewed focused efforts in that. And I think COVID-19 has made all of us, reconsider, priorities in our own personal lives and also in the medical system. And, we had to go through some difficult exercises as health system leaders. It never came to this point where I live in Canada, but we had to prioritize which cancer medicines and treatments we would deliver if the health system started to fall apart. And we never got to that point, but we had to have these sober discussions about if we had very limited capacity, which treatments would we continue with, which ones would we stop? And in doing that, we realized there's some stuff at the bottom of the list that we probably just don't need to resume, and patients will be better off. It'll spare them side effects, save their time, and save resources for the health system. So I think there are some things that we can learn, but I think we're going to need to retain a global mindset.
Thank you. Thank you all of you for participating. We are planning as the coalition to do more work on this in the form of a roundtable meeting early next year. Maybe we'll be calling back on you for some insight and input into that. We're just about to close this session. And don't forget, coming up, we have a movement break delivered to us by one of our newest members, the Dempsey Centre. That's on the next list on your programme. And then at 15 minutes past the next hour, wherever you are, you'll be able to choose between one of our 2 live workshops. So one is on expanding your social media reach, tips from some experts on how to get even further. I think Runcie should be delivering this one actually. And the other one on inclusive care. So how to ensure LGBTIQ people affected by cancer have inclusive care for their cancer. And we will feature the experiences of one of our partner organisations, Overcome in the UK, in showing what they've done to address this as well. Don't feel you're missing out on one by choosing one over the other, because the sessions will be recorded and be available for you to see again tomorrow, so you can always pick the other one tomorrow to have on demand. And there is also a session on leveraging your not-for-profit status, so making the most out of being a charity, tips and tricks on how to get free Google advertising and things like that. So lots to look forward to. So stay with us for these sessions, and don't forget, I should say, to come back tomorrow at 2:30 UTC. Thank you, Chris, Julie, and Runcie for a really interesting discussion.
Thanks, Francis.
Bye, everyone. Thank you.